Thank you all so much for joining us today. We're going to be discussing various case studies on improving mental health. This is now our third workshop in a series of workshops responding to the new Labour government's priorities. And quite helpfully in that period of time that we've been delivering these, the Lord Darcy report's also landed as well, which has done a fantastic job in framing the issues that I think many of us knew we were experiencing, but also just really bringing them to the forefront for people who are sort of less experienced within the world of healthcare as well. Do hope you enjoyed today's session, and do please consider joining our other workshops if you enjoy today. I know that the team behind the scenes are working really hard on bringing you a variety of other topics as well. So just quickly, a bit about myself. My name is Tom Myers-Jocelyn, and I'm one of the lead analysts at Unity Insights. I joined this world in about 2017 when I joined Kent Surrey Sussex Academic Health Science Network. And in that time, I've been responsible on leading numerous projects delivered across England, having mass impact across ADHD pathways, wound care pathways, respiratory, and cardiovascular disease. And more recently, I've had a particularly interesting piece of work about system-wide mental health transformation within the community setting. Unity Insights, we offer analytics and evaluation services to the NHS as a social enterprise. And we've got numerous partner organisations across the Health Innovation Network, with regional and local NHS bodies. We work very closely with industry and innovators and also with academia. And I'll allow Sage to sort of introduce herself.
Thanks, Tom. Good afternoon, everyone. My name's Sage Bannister, and I'm a lead analyst at Unity Insights. I did join KSS shortly after Tom, so in 2019. And I suppose sort of my role at the company sits a bit more on sort of the real evaluation side of things. A lot of the time it's conducting health economic models, and obviously in sort of the mental health space that can get a little bit interesting, obviously because you're trying to quantify qualities and changes like that. In terms of my work specifically on mental health, we're going to talk a little bit later about a case study on a project called Stay Alive, and I was the analyst involved in both the evaluations. So we did one in 2020 and then an updated one in 2024.
Thank you, Sage. So just broadly, as an agenda, we're going to be discussing the challenges, again, utilising that sort of Lord Darcy report to really frame the challenges being experienced across mental health services currently, and then demonstrating impact. We're going to present to you a couple of case studies of a service transformation and a digital innovation that we've recently evaluated, show you the various methodologies that we've utilised and some of the outcomes that were realised as part of those projects. And then we'll try and sort of summarise that with some key takeaways at the end of the session. So the challenge and the vision. We've got a slide here which highlights at a top line, as we were discussing, some of the significant challenges being experienced at the moment. And I wanted to identify just 3 key ones to me personally. So firstly, we've got the increase in demand, and through the Lord Darcy report, we identified that 3.6 million people were in contact with mental health services in 2024, which alone is a large number. However, understanding that that's actually increased from 2.6 million in 2016. So quite a significant increase over the past few years, somewhat amplified as well because of the pandemic. Another key issue is access to care. And we've got an understanding now that in April 2024, about 1 million people waiting for mental health services. And the case study I'm going to present really tries to identify ways to bring down the barrier to access to care, but also try and improve the speed in which people can access services. And then finally, workforce shortages. And we've got an understanding as well that the mental health workforce has somewhat reduced by 9.4% between 2010 and 2016. Although it has slightly increased ever since. And sort of pivoting back to the Labour Manifesto and their sort of main ambitions, we're looking to bring down waiting times and intervene earlier, 2 key areas of the system transformation I'm going to discuss. and also aim to increase staffing numbers by another 8,500. The two key ones on this slide for me are bring down waiting times and specifically training new staff to support those at risk. And I've pulled together a few sources from the top chart here is actually from the Lord Darcy report, and the bottom chart is actually from the BMA. And this Lord Darcy chart here at the top does a fantastic job of, again, expressing the wait times being realised by patients waiting for help in community mental health services. And this number here of people waiting 18 weeks or more, or even more than 52 weeks is significant. We're looking at over 300,000. Well, yes, somewhat over 300,000 people when you include over 12 weeks. And particularly shocking, I actually thought, was this bottom chart produced by the BMA. So the yellow here is what we've got is an indexation of the sort of the full-time equivalents currently delivering mental health services versus the number of people in contact with those services. And as we can sort of see, the index number of people utilising the services has exploded massively over the course of about 6 years. However, the actual number of staff delivering mental health services has not followed pace, and we're really starting to realise that now. So, demonstrating impact, I'm going to present here now a case study on community mental health transformation. And so throughout sort of 23-24, we were commissioned by a ICB to go about evaluating the system-wide transformation that they had been implementing over a course of 5 years. So the NHS long-term plan and the NHS mental health implementation plan had set out an ambition for developing new integrated models of primary and community care. And also sort of supported by around £1 billion of additional funding by 23-24. And this particular ICB that we worked with was one of 12 who had received additional funds to test this new model and act as an early implementer site. The transformation at which they underwent was absolutely massive, to be honest. And this sort of chart in the top here identifies the number of additional and new services or transformed services that they went about implementing over the course of that time. There's a lot to talk about here, but there's sort of 4 key areas which we really honed in on as part of the evaluation. The primary one here being GPIMS, which acts as a bridge between primary care and secondary care community services. It works by installing sort of multidisciplinary clinical and non-clinical workforce in PCNs, and provides early intervention for adults and older adults with non-urgent but nonetheless significant mental health needs. So the idea here was really to bring down the barrier to entry to these mental health services. And so one of the key aspects of this was that people did not require a mental health diagnosis in order to utilise the service. But the actual implementation of GPIMS across the county was vast. There are some additional services which we paid particular attention to as well. There were 3 new services around complex emotional needs, which again sort of included service users networks to offer support. There were additional self-referral programs such as managing emotions, and there was also staff training programs involved there as well, so that staff could also engage with patients and better understand and assess their needs on the spot. So ultimately, we were sort of requested to deliver a complete package as part of the evaluation, which involved sort of providing quantitative findings. We did dashboards, but the most interesting elements of the analysis really was the cost-benefit analysis and the system dynamics modelling that we delivered. And I'll sort of talk through those in more detail in a moment. It's also really important to highlight that we did extensive focus groups and interviews with people involved in the transformation of the services and the delivery of the services to understand the barriers to implementation and how they would go about the implementation again if they were sort of given that opportunity. And all of these findings were sort of wrapped up in one final report. I think oftentimes when we have people come along to these sessions, it's almost preaching to the converted already, but why go about evaluating? It's really key as it provides a critical assessment into the delivery of your innovation or your pathway, and whether it's actually meeting the aims and objectives that you set out to achieve. I think all too often we're keen to make a change and we really dive in head first into implementing new things. But it's quite rare for us to have the opportunity to actually take a step back and assess whether it's working and see whether we could actually sort of pivot our implementation or see whether we can move it to another region so that they can benefit as well. So we just sort of go about setting out a series of questions that we're aiming to answer. Is it actually, as I sort of readdress, is it actually helping achieve a particular ambition? Can we replicate this elsewhere? We've got networks across England now which are commissioned centrally to spread innovation and pathway transformation from one region to the other. So it's really key to understand the barriers to that implementation, whether they'll be experienced in other regions or not. So here are some sort of typical methods that we would utilize as part of our evaluation. And I think it's really keen to stress that ultimately what I've described so far was a mixed method evaluation that we delivered, but it sort of leveraged very heavily on the health economic studies, the qualitative studies and some descriptive studies as well. But all of these sort of tools here are very applicable depending on the sort of the question and the answer you're trying to deliver. When it comes to this particular project, again, so within the descriptive studies, we were really sort of fortunate to have a lot of clinical audit data, and we were able to access all of the service data as well. So understanding the number of appointments, the number of referrals to all these new transformed services was key in understanding whether the uptake was being realized, but also whether the desired outcomes were being delivered as well. Were patients able to access services earlier, but also were they then having lower resource utilization in other services? Were they having to attend GP practices less? Did they have fewer did not attend? Did they have fewer arrivals at A&E? Were all questions that we were trying to answer. So again, that was sort of very high level. We had 3 key data sets in this project that we were able to sort of leverage to provide a cost benefit analysis, a system dynamic model, and also provide some headline statistics on reduction in resource utilization. Key to that was this NAPC audit, which provided to us an understanding of the reduction in the number of GP appointments, the number of did not attend, and the number of hospital contacts that patients who access GPIMs sort of realised in ongoing years. So I think what was really impressive in this sort of analysis was what we understood was that GP appointments for patients who receive GPIMs in the years subsequent to their referral actually dropped by about 22% in the first year. And then we saw sort of subsequent drops of 18% and a further drop of 29%. And as we sort of look further, it became a little more crystal ball because we had fewer patients who access those services for such a period of time. But nonetheless, it was a really key identifier when working within the focus groups of understanding whether GP practices were having less burden or less interactions with these patients. So with the understanding that we sort of reduced GP appointments, or not we, but we've been able to identify that a reduction in GP appointments for people interacting with the GPIM services was at about 22%. What we went about doing next was a health economic study. And there are a number of health economic studies, and the application of a model really depends on the question and answer again that you're trying to sort of articulate. In this particular example, we went for a cost benefit analysis. And the reason for that was that this was a service transformation which didn't have any one particular outcome. We were keen to understand whether there were fewer GP appointments for patients who were receiving these new services. We were keen to understand whether they had less A&E visits, and there were also social benefits that we were trying to articulate as well. Now that they're receiving care, are they able to provide more input into the economy through work and requiring less social care? But there are other models that can also be applied as part of your evaluation into transformed services. Particularly key and with NICE is looking at cost effectiveness and cost utility. And these models work ever so slightly different. Whereas the cost benefit, you've got multiple outcomes that you're trying to monetize and you put a pound sign on them. Cost effectiveness, you're looking at achieving one particular outcome. So for cost effectiveness, it might be you're looking to reduce solely bed days, and you're trying to understand, if I put in an amount of capital funding, how many bed days does that save me? And cost utility's got a very similar approach. However, the unit that you're looking to express is QALYs. So a sum of about £20,000 according to NICE. As I say, for this particular model, we went about a cost-benefit analysis. So the tables sort of presented to you now are the outcomes of that cost-benefit analysis. So within that, we accounted for a reduction in GP appointments, did not attend, and hospital contacts. And what's really key is to sort of differentiate the two scenarios here, one without disability adjusted life years and the one with disability adjusted life years. So without, it's solely looking at your return on investment, looking at NHS healthcare resources. So we were simply looking at whether the sum of the GP appointments avoided was greater than the capital funding that went into delivering that GPIMS model within a particular PCN. And ultimately what we found was that for every £1 invested, you got a return of 68p on a sort of realised through that reduction in GP utilisation. However, what was also key finding is that when you included disability adjusted life years, those savings really ramped up to a total of £2.54 for every £1 that we sort of saw invested into services. But oftentimes providing just a fixed point can be quite risky, and it doesn't necessarily sort of show the potential risk in moving that innovation from one location to another, or it doesn't necessarily account for some of the uncertainty in the data that was available to us. And a lot of times when you're doing these service transformations and then later coming back to evaluate them, you'll understand that there are various sort of risks and various caveats to the data that you've utilized in order to generate your return on investment. So what we always do is we always provide a sensitivity analysis as well, to suggest that within a sort of 90% confidence interval, you realize a return on investment between a minimum and a maximum point. So in this particular example, what we were able to suggest was that the mean on the previous slide was about minus 250,000 for your 68p return on investment. However, this may have been anywhere between minus 291,000 and minus 207,000. Another sort of really sort of difficult conversation that we had to have was that ultimately what we're presenting here is a case study where the amount of money which went into transforming the service was greater than the amount of money saved, which is always a difficult conversation to be had with commissioners or with innovators. And so what we had to do, in addition to providing a health economic analysis, was provide a sort of systems dynamics model to begin to evidence how many additional people actually access these services? Yes, we have not generated a positive return on investment with regard to money, but are more people now accessing services? Are we addressing what was once an unmet demand? And so we went about deploying a system dynamics model, which at its very core is a stock and flow model. What we can do is we can set up numerous nodes, a node being a service in this particular example, and begin to flow patients into it and flow patients out of it once they are treated. It's a really useful tool for understanding within transform services, where are patients going to go and are there any particular bottlenecks? If we develop services that do not have enough capacity to treat the number of patients that are going to flow into them, are you producing a new waiting list? Are these people going to deteriorate faster whilst they are sat in this new waiting list, or are they just going to become stuck in the system and never be able to get out? So we went with the SDM, we sort of had 4 key areas: unmet need, and 4 key aims that we were sort of trying to articulate with our system partner. And in all honesty, this was a massive challenge. The size of the system transformation was unlike something that we'd previously worked with, and even working with systems partners, there were very few people who were sort of in the level of the detail to be able to understand how every system interacted with each other and how patients may move from one particular service to another. And so it took an extensive mapping exercise to really articulate if a patient enters in at a GP practice, how are they then referred onto GPIMS, and where from GPIMS can they potentially go as part of this system transformation? Can they receive further assessments within the complex emotional needs team? Do they need additional support around eating disorders? Could they be referred into the service user network and receive support there? There was no one defined pathway, and that any service was open to a patient depending on their needs. And so I would say my poor colleague Pete had a real challenge in trying to articulate and identify where patients could go and try and map the flow of patients. And a particular challenge that we had was identifying what the unmet need was. Our understanding was that patients were unable to access GP practices, and so were just sat within the community, potentially deteriorating. But by providing the system transformation and unlocking new services with lower barrier to entry, we had a new influx of patients. But what it meant was that we were still unable to articulate what's the unknown gap. How many people are sat with a mental health need, but the NHS community services teams were unaware of it, which was particularly key in them being able to identify how many additional people had actually been through the service and how many additional people were waiting to go through service. Ultimately, we were able to sort of evidence that an additional sort of 1,300 people per annum are now able to access his services that did not previously exist within the managing emotions program and within the service user network. And then we still had additional challenges in identifying the number of people accessing GPIMS and the other transformed services. But nonetheless, being able to articulate just these small numbers was of massive benefit to counteract that almost negative health economic return that we were presenting at the time. I must admit, trying to articulate this in a 200-page report was challenging enough, let alone having 20 minutes to try and to present all of those findings as well. And as I suggested earlier on, we also went deep into the implementation science and working in focus groups and working with one-to-one interviews to really understand the barriers into developing these transformed services as well. And so that was a real whistle-stop tour of a community transformation that we sort of recently undertook, and a few examples perhaps of the various analyses which are possible as part of that evaluation as well when trying to evidence the impact that you've had. I think we'll just pivot onto Sage now and Stay Alive. And Sage, if you want to introduce Stay Alive.
Yeah, great. Thanks, Tom. So on a slightly less technical note, so Stay Alive was a bit more of a rapid evaluation. But obviously it kind of shares some of the challenges, and there's a couple of some of the same health economic models that were used for the first evaluation, which I'll get into a little bit later. But yes, this will be slightly lighter than Tom's technical detail, although I suppose still quite a heavy topic because we're addressing sort of prevention of suicide. So another example of how we demonstrated impact was through this independent evaluation of a Stay Alive app, which was developed by a charity based in Brighton called Grassroots Suicide Prevention. As I'm sure you'll know, and as mentioned at the start of the presentation, so patients experience difficulty in accessing mental health services due to a number of reasons, which include the high demand, lack of workforce, a fragmented system, and then obviously the stigma around the topic as a whole. So just a couple of brief points then on the specifics of the Stay Alive app and the charity. So the Stay Alive app was created and launched in 2014 by Grassroots, and this serves as an accessible suicide prevention tool in the UK. It's won multiple awards, it's approved by the NHS, and it is available in 14 different languages. It's also been downloaded over 800,000 times worldwide, and that was of April 2024. It's free and confidential, and the app offers support and help and useful. So it offers support and help through providing sort of signposting to useful resources, and that's both for patients that are experiencing, suicidal ideation, suicidal thoughts, and those that want to help others that they're concerned about as well. Next slide, please, Tom. So in terms of a bit of a project overview, so the Stay Alive app tackles several of the problems that are highlighted in the Darcy report. And I would basically say that the access to care, increasing demand, and the fragmented care pathways, those are basically covered off by the solution's ability to be able to signpost relevant resource and enable sort of pathway navigation. In terms of the stigma around mental health and that mental health issue, this app, some of the findings have basically said that the app helps encourage people to talk openly about it, and it also provides some educational resources in terms of suicide and improving awareness as well. Next slide, please, Tom. So getting a little bit under the bonnet then in terms of the two different evaluations that we did. So we did an evaluation in 2020, and the sort of core elements of this evaluation is that we did an opportunity cost model to try and understand sort of the overall cost of reducing suicides in the UK. So this opportunity cost model is a slight variation from the model that Tom was talking about earlier, which is the cost benefit analysis. And then using surveys, we came up with a proxy figure for the efficacy of the Stay Alive app in preventing suicides. And then the current evaluation that we did finished in March this year. That didn't have a health economic element, but what it did have was some qualitative and quantitative analysis. We were looking specifically at trying to understand app reach and user engagement, effectiveness of the app in preventing suicide, improving ease in navigation and the pathway, as well as user experience. One thing to highlight is that we used the 2020 evaluation as a bit of a proxy baseline, and I'll get onto that a little bit later in the slides as to why baselining is important and actually why it's quite difficult to obtain in sort of the mental health space. And then in terms of the qualitative data, we got that through surveys. So basically users of the app answered a couple of questions, and that was analyzed. And then a lot of the quantitative insights came from app data that was provided by the charity, and we were able to understand a little bit more some of the details around the patient cohorts accessing the app, which areas they were accessing the app from, etc. Next slide, please, Tom. So what did we find? Basically, there's a high volume of users accessing the app. As you can see, there are over 100,000 users in the UK for 2023. Large proportions of the users felt that the app helped them stay safe from suicides. That was about 76%. And then 80% of those felt like the app was really useful in terms of highlighting resources and the correct sort of pathway to be able to find help. So also in terms of navigation and accessing resources, as I said before, the Stay Alive app provides a variety of signposted external resources to the app, as well as their internal resources. Some of the internal resources include like being able to save pictures or being able to save emergency contacts and that type of stuff. But the National Crisis Support Resource, so this includes the Samaritans and Calm, was voted as the most used externally signposted resource by the respondents. And this was followed by local crisis support UK resources, so NHS trusts and local charities. And then lastly, 93% felt that the app helped reduce stigma around suicide, and 73% felt that the app facilitated talking openly about suicide. Next slide, please, Tom. So it's really important to note that evaluations aren't always plain sailing. And I think a lot of the challenges that we had across both the evaluations actually weren't as a result of, say, poor evaluation design, but I think it's quite intrinsic just to the sort of mental health landscape and how sort of fragmented all the data sources are. And I suppose rightfully so, there's a lot of, IG data protection systems in place that obviously make sometimes linking those data sources really, really challenging. But I suppose all these challenges can be sort of tied under the theme of data accessibility. So as I was talking on an earlier slide, absence of a baseline. So this is challenging because establishing a baseline in mental health evaluations is difficult due to variability in how individuals experience symptoms, differences in diagnostic criteria, and sort of the subjective nature of the mental health assessments. Mental health conditions also fluctuate over time, and a single baseline point may not capture the true extent of a patient's condition. Additionally, there's no universal standardized method for baseline assessment across mental health disorders. So what we've suggested to kind of tackle this, and obviously it's good to bear in mind when you do your own evaluations, it's just basically encouraging a standardized tool for baseline assessment. And this will help obviously create a consistent basis to start from, as well as longitudinal monitoring over time, because then this can help us understand the nuances as people progress. And I think this is linking back again to some of the data points Tom was talking about with DALYs and sometimes QALYs as well, because you obviously don't want to assume that that's fixed for the entire duration of the illness. Linking of data sets. So mental health data is often fragmented and scattered across multiple systems. As you could see from all of Tom's diagrams, there's so many different access points and pathways that patients can travel down. And that's spread across hospitals, primary care, specialized mental health clinics, and social services. And sometimes these systems don't communicate with each other, and differences in the data formats, terminology, and privacy regulations make it quite difficult for us to link those data sets. So obviously what we've suggested is a bit of a identifier across those data sets so that they can be merged. Obviously that's a very big project and probably something that would need to be adopted nationally for it to work. And we've also suggested a couple of points around data sharing agreements to sort of foster that collaboration and data sharing between different entities. Aggregated and anonymized data. It's crucial for research and large-scale evaluations, but it's challenging due to the risk of re-identification, especially in small, unique populations. And I suppose this also becomes quite a problem when we're looking at sort of health inequalities data as well. So de-identifying mental health data while retaining its utility is quite complex, because obviously if you anonymize it, you lose a bit of the nuance and complexity, and then obviously limit the findings that can come out of that. So one of our suggestions is to use advanced anonymization techniques to allow data to be shared in formats where patients aren't at risk of being identified, but obviously providing enough nuance to enable sort of the evaluation, which again, I think would be on a sort of case-by-case basis and would be ideal if that's done, prior to the data collection taking place. And lastly, aligning outcome measures. So in mental health, studies and clinical settings often use various outcome measures to evaluate treatment effectiveness or disease progression. Again, sort of like the first challenge, the lack of standardization makes it difficult to compare across different evaluations or clinical trials. So, for example, some studies might focus on symptom reduction, while others may look at quality of life or functional improvement, which creates discrepancies in how success is measured. So one of our suggestions is to create and promote universal standards for mental health outcome measures. Again, that's something that's going to have to be, for it to be as successful as possible, needs to be adopted sort of nationally, and there would be input required from multiple stakeholders. And to sort of develop a crosswalk tool that will map different outcome measures to each other, allowing researchers to compare and integrate data across studies using those different tools. Thanks, Tom.
Thank you, Sage. So what we've done is just wrap up the two presentations in some key takeaways. I think Sage has actually just done a fantastic job there of defining some of them already. But here they are. So particularly around pathway mapping, and in my own sort of particular example, understanding the pathway, particularly in service transformation, but also when embedding digital innovations, can be really challenging. It can be an arduous task, and you will have to have discussions on understanding the sort of the logical limits to that path. But whilst it feels like a very time-intensive activity at the start of any program or any evaluation, the time that you receive back through not having to have discussions of re-understanding the pathway makes it a significant sort of worthwhile investment. Understanding your data on the implementation of a program is also key. And we recognize that, especially within community services, the data sets can be so fragmented and sat in unique locations depending on the service provider, that sort of drawing those together to be able to fulfill an evaluation can be particularly challenging as well. And so, again, being on the front foot, fostering those collaborations between service partners, and sort of trying to promote the sharing of data and the setup of data sharing agreements can be something which buys you a lot of time early on in your program implementation, and sort of you'll sort of reap the rewards later on in the life cycle of the program. Trying to consider attribution is particularly challenging as well, especially within the mental health space. And as we were sort of present, the reduction in GP appointments within community transformation was quite significant. But understanding the attribution of having new services available to patients was something which we still struggle to fully grasp. And you never really will without being able to sit down with patients on a one-to-one basis. However, that has got its own challenges as part of an evaluation. And sort of the last sort of takeaway is sort of ensuring that you've got your clinical buy-in, especially within the implementation and the evaluation. They are oftentimes the greatest source of information in understanding how you break down barriers to spread and adoption of your innovation or your pathway. And without having them on side, you'll really sort of struggle to communicate to other teams the benefit of your sort of your program, especially if you're looking to shift it from one service to another. So with that, I'd like to say thank you very much to everybody who has joined us today. I recognise there was an awful lot of content there for what was about 35 minutes in the end. This is one of a number of workshops that are being delivered. And here is a sort of a schedule for future workshops. Should there be anything which sort of takes your fancy there, please do reach out to us. Our sort of contact details are in the calendar invites. We'd love to hear from you again. But yes, thank you so much for joining today, and I hope you have a lovely rest of your day.